The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
All right, thank you for your patience. This is Limi Children's Hospital in Abuja. We are making this presentation as part of our contribution to community development, our corporate responsibilities. So we want to make these presentations, but first of all, we want to let us know we are Limi Hospitals, and the Limi Hospitals have 3 branches. The headquarters in the Central Business District of Abuja. We also have Cardio Care, which is the cardiovascular multi-specialty hospital for internal medicine with heavy focus on cardiology, where our cath lab is situated with a lot of interventional procedures currently going on for adults. And we will hear more about our moves towards pediatric intervention subsequently in this presentation. We also have the branch Limi Children's Hospital, from where we are presenting Limi Children's Hospital. Well, we've been in existence since 1982, so we are not Gen Z. We've been in existence since 1982, and we just keep waxing stronger and stronger. We will go into the business of the day immediately. Yeah.
I'm Dr. Ayomide, Oshagbami.
Okay, I'm Dr. Igoche Peter, and we're presenting pulse abnormalities in children today. So we get to meet children every day, and we hear get a lot of referrals, hear a lot of complaints about, oh, this pulse rate is below what it should be, presumably. I say that because we'll have a table to discuss that. And also, oh, it's irregular, and so get an ECG done. But then ECG is done, and then we keep getting snapshots from different parts of the country. And at the end, sometimes it's actually one of those normal variants, right? So we want to do justice to this topic today, and we hope that we shall have a smooth ride together. Yeah.
So I'm talking about the objectives of today's presentation. One is to identify pulse anomalies by the bedside or clinic.
Yes.
And also to highlight normal variants, as well as interpret ECG findings associated with abnormal pulses.
Yeah.
And then the last objective is to understand the basic care of pulse abnormalities in children.
Yeah, so it's important that everybody taking care of children will be able to identify and at least do something to keep the child alive before referral if need be. And it's important we all know the variants of normal to reduce anxiety among physicians, right? Okay, fine. So we kick start.
Okay, so looking at this clinical case, which we'll be talking a bit more on a little later, but just to get our attention, it's one of the children we had, and it's a picture from our center. So it's a 2-day-old male neonate that was delivered at 41 weeks, 5 days, and referred to our center for mechanical ventilation. And now looking at the ECG tracing, we'd like to know what the heart rate is and what rhythm this baby has, as well as keep in mind possibly way to treat this condition when identified.
Yeah, so we cannot wish everything away, and we cannot reassure every case we see. So the wise person knows when to reassure, when not to reassure, right? So what could this possibly be? We will not request for answers immediately, but let's just be ready to make it very interactive by giving response when it is called for. We will really appreciate that. We'll delve into the presentation properly. Yeah. Okay. Well, these are the traces of the images, pre-treatment, post-treatment. We can see we have a difference. So along the presentation, someone will tell us what this is and what we did to get this tracing. Yeah. Okay.
All right. So talking about the pulse, right? So basically there are 3 things about the pulse that we should have in mind, and which we'll also be talking about in this presentation. The first is the rate, which talks about the number. The second is the volume, and then the last is the rhythm. However, for the number, it's very important to understand that in pediatrics, depending on the age of the child, the values that is normal for every individual or every child varies. So using this as reference ranges, it's important for us to know these normal values. So when you see let's say a 1-year-old child and you check the pulse and it's, let's say, 110 or 115, you're not exactly worried because this is normal for the child. However, you see a 13-year-old adolescent that comes in with a pulse of 110, you should be concerned that, okay, something going on here. Is it high or?
Yeah, so the beauty of pediatrics, which I will always like, is a dynamism. Knowledge is not static for pediatrics. So you look at the age variation across age ranges and variation across physiologic states. So if we take the pulse rate when the child is awake, we find something faster than when the child is asleep. We also understand that it varies with level of anxiety, it varies with temperature. As temperature rises, so the context in which the pulse rate is taken matters a lot for us to make our deductions. But in any case, when we take those values, whether it's fever and it's above the normal range, is tachycardia. If it's below the normal range, is bradycardia. And of course, normal is normal dependent on the age of the child. Right. Okay.
And then also, so here we talk about the volume, which I will talk about first. So basically, to establish the volume of the pulse of the child, it's important to palpate.
Yeah.
While palpating, you want to check, is it a normal volume? Is it a small volume? Yeah. Also, looking at the rhythm.
So still on volume, it's important we note that this presentation will dwell very little on volume, but there is a place it will come up very handy. We've made a presentation in our webinar series on pediatric shock in children, where we talked a lot about pulse volume. So if you subscribe to our channel, you could locate that webinar we've presented some time back. But if we check we're going to determine in our algorithms ahead, is this child in shock? The volume of the pulse and the rate becomes very important
to establish
them. But for now, we'll talk more about reading.
And also looking at the rhythm, also first you can establish this by palpation. So you want to check if the rhythm is regular, which you'll be able to feel, or irregular. And by using the ECG, you can also determine if it's a sinus or non-sinus rhythm.
Yeah.
However, it's very important to know what the normal is so that if you have any variations away from this, you can determine if it's sinus or non-sinus.
All right. Thank you. Sorry for the break in transmission from our Limit Children's Hospital channel. All right. So what is sinus reading?
Right. So to establish that the rhythm on the ECG strip is sinus, there are some parameters that need to be constant and established. And the first is we have to look at the P wave. Are all the P waves, are they similar and are they normal looking? Then also you look at the lead 2 as well as the lead ABR. So in lead 2, if the leads are placed appropriately, P wave is always upright. However, in lead ABR, it's inverted. Also, you also want to check if for every P wave, there's a succeeding QRS complex. And also looking now at the QRS complexes, you want to look at the QRS complex. Is there a P wave preceding the QRS complexes? Now, this might seem like a repetition, but when you look at the ECG strips, you tend to understand why it's important to establish both the succeeding and the preceding wave.
Especially when we go to AV blocks. Also,
also want to look at the R waves. Are the R waves at the R to R interval, are they equal? If all 5 are established on the rhythm, then you can, on the strip rather, you can say that this is a sinus rhythm. However, if there is a variation with 1 or more, then it's unlikely to be a sinus rhythm.
Yes, yes. So the P wave characteristics and the QRS complex characteristics, those are constant characteristics. If we have any aberration in P wave or QRS complex characteristics, then it's not sinus. The RR interval should be equal. However, if every other parameter is normal, but we have unequal RR intervals, then it could be sinus arrhythmia. And in such cases, many times it's a variant of normal. When you have normal heart rate, pulse rate, and the ECG is otherwise normal, apart from that the RR intervals have some variation, that would be sinus arrhythmia. So the bulk of the presentation will be dealing with abnormal rhythms. So we'll look at abnormal rhythms in details. Good.
Okay, so this is a rhythm rate matrix.
Okay, so we in Limit Children's Hospital, we thought it was wise to simplify this as much as possible. So we developed this matrix, right, to make it as simple as possible for anybody who wants to understand arrhythmias in children, the classification. So we have 4 quadrants, A being sinus, B being non-sinus, C tachycardia, and D bradycardia. So if we look across the quadrants, we can classify what it would be, right? So if we have A and C is sinus tachycardia, which we have here. If we have A, D is sinus bradycardia. If we have B to C is tachycardia, that's BC is tachycardia. It's tachycardia, right? But it's non-sinus, so it's arrhythmia. So that's why it's tachyarrhythmia. Now, if we have A to D is bradycardia, right? Sorry, we say B to D is bradycardia. But since the rhythm is non-sinus, it's a sinus bradycardia. Okay. So we will look at sinus tachycardia, sinus bradycardia. Then the tachyarrhythmias, we have them as as shown.
Okay, so for the tachyarrhythmias, it's called looking at the QRS complex, right? So if the QRS complex is narrow, which means it's less than 2.5 boxes, then you start thinking, is this a supraventricular tachycardia? Is this an atrial fibrillation or an atrial flutter? Each has its own unique manifestation on the ECG to be able to identify which is which.
Yeah.
However, if the QRS complex is greater than 0.09 seconds, right,
Yeah.
then you start thinking, is it a ventricular tachycardia or an unusual supraventricular tachycardia?
Yeah. So we shall see all this. Now, if it's a bradyarrhythmia, we'll be discussing AV conduction disturbances. But the sick sinus syndrome or the sinus node dysfunction is another entity to be discussed among bradyarrhythmias. Okay, so we have sinus bradycardia.
So looking at this ECG strip, this is an ECG strip for a 5-year-old that presented. Now, if we try to establish what a sinus rhythm is, once we look at the P wave in the lead 2.
So this is lead 2, this is P wave.
And it's upright and
so it's upright. There's P wave before each QRS complex. And before each QRS complex, there's P wave. It's upright in lead 2, and then in AVR. Okay, yeah, so fine. So we have P waves there also. Okay, fine. So what about the rates?
Now, if we're to establish the rates for this ECG strip, and then we check the out to R and then determine the rate. So see that this rate is about 46, thereabouts, which in a 5-year-old child is bradycardia. And honestly, regardless of the age, with that value, it's bradycardia for all age groups.
Yes, yes. So this is bradycardia. So let's delve more into bradycardia in this discussion. Good. Wow. Okay, fine. So what could possibly cause bradycardia in children?
Well, first is we have normal variants, so like more or less a physiologic bradycardia. But this is seen more in athletes. So of course you won't see an infant being an athlete. It's probably going to be a teenager.
So it will sound very funny because we would reassure a trained athlete who has bradycardia after ruling out other causes and say it's physiologic. Sorry, then somebody is reassuring the mother of a 1-year-old that the bradycardia is a normal variant. I mean, it doesn't make sense, right? Because a 1-year-old cannot be an athlete. So we find bradycardia at the age below the age where someone can actually be a trained athlete. We cannot reassure. We have to delve in further. So there are some abnormalities that could cause bradycardia.
Also, other conditions associated with sinus bradycardia are vagal stimulation. So let's assume a child was suctioned, and maybe while suctioning, the vagus nerve got triggered. It could also result in bradycardia.
Yeah, so interestingly, just as a deviation, I was intubating a unit this morning, and because I had this presentation, the pulse oximeter was connected. And every time the laryngoscope gets in, you see the heart rate drop. So vagal stimulation, that's like gag reflex,
Also, beta adrenergic blockers, which are medications, could also cause this. So you want to establish in your history, is this child on any medication or not? Another condition that could result in sinus bradycardia is increased intracranial pressure, which you can find in conditions such as presoccupied lesion in the brain, or even in meningitis.
Raised intracranial pressure complicating meningitis.
Yes. Also, hypothyroidism, hypothermia, and hypoxia are also conditions that could result in sinus bradycardia.
Yeah. So, okay, sorry, a little more on vagal stimulation. So sorry, a little more on vagal stimulation. What other things could cause vagal stimulation, right? For example, breath holding spells. somebody who has had Valsalva maneuver that's in forced expiration through closed glottis. All those things should be known. Somebody who had just fainted, we bear that in mind while we evaluate the differential diagnosis of sinus bradycardia. Whatever the cause of sinus bradycardia, we want to be careful to reassure because it's often a pre-terminal event. It's often a pre-terminal event, right? And then usually children who have bradycardia, cardiac output drops, right? Cardiac output drops below what is expected, right? And if untreated, if unaddressed, yeah, so it could just be the end of the road. So, but which drug do we use to treat bradycardia? Yeah, so look at management. We treat the underlying cause. So it's not like malaria that you want to give anti-malaria. It's not diarrhea disease you want to give ORS, right? If we have bradycardia, the onus lies on the managing physicians to identify the cause and address the cause. Yeah. Okay, fine. So when we say treat, how do we treat? We have this algorithm.
So the first thing you want to establish is shock present?
Yeah.
Or not?
So how do we identify if shock is present? We palpate the pulse, right? We palpate the pulse. So we check if pulse is present. If the child has shock, then the management, the algorithm tracks differently. If the child does not have shock, fine. So of course, shock on its own is an emergency. So you quickly try to treat the hypoxia, get vascular access to rehydrate as fast as possible. You can do something for that child, right? So if, of course, we give boluses of crystalloids, 20 ml per kg, as fast as possible, give oxygen to get the child out of shock. Then we check, is there vagal overactivity, right? Was there a cause? Was there a history of breath holding spells? Was there syncopal attacks? Any of those things we get to know quickly. Was the child coming from a swimming exercise, a diving reflex, right? If the answer is no, we quickly, with our vascular access that we used to rehydrate, to give anti-shock, we give adrenaline. Or if yes, if there was, we give atropine. Atropine is very important, we give at that point. So that would help. Atropine is catecholamine. It will help increase the heart rate. That's positive. Yeah, so adrenaline, right? It will increase it, so has a positive chronotropic effect. If that is unsatisfactory because this is push, then you consider adrenaline infusion and consider pacing, insertion of pacemaker. However, if the child was not in shock, but bradycardic, right? Expert opinion is sought. It's absolutely necessary. It's absolutely necessary, but not an emergency that you may be able to handle immediately. Right. Okay, fine. So we'll proceed in the presentation. Good.
Okay, so this is also another 5-year-old child. And this is the ECG reading that we got. So from this ECG strip, we want to also establish if it's a sinus reading or not a sinus reading. So we look at the parameter, look at the P wave, the relationship to the QRS, look at the placement in the tube as well as AVR, and then count the rates of the child. However, it's very important to note, which we'll be discussing a bit further, but for an infant, right, we make an assessment of sinus tachycardia.
Yeah.
If the the heart rate is not more than 220.
Yeah.
However, if it's a child, you look at not more than 180.
Yeah.
Any values above this in this group, you probably will start thinking of something a little bit more than sinus tachycardia.
Yeah. Okay, fine. So what is the heart rate here? So we are counting the number of beat boxes between the RR intervals.
This is about 150.
So it is about 150 in a 5-year-old. So for children, it's below, here it's below 180 beats per minute. So, and then we have all the parameters positive for the sinus reading. So this is sinus tachycardia. So what are the possible causes of sinus tachycardia, which we will see? Yeah.
So one of the commonest cause really is anxiety. So when you're anxious, you tend to feel the anxiety, and as a result of that, your heart rate goes up, and then of course there'll be tachycardia.
Yeah.
Other things are catecholamines. So basically, in reflex to fight or flight. So anything that makes you anxious, a bit.
Yeah, so any stressor,
yes.
stressor releases catecholamines, and once catecholamines are released, so this is a physiologic release of catecholamines, right? When we were looking at the algorithm to treat bradycardia, we said we give adrenaline. So that is therapeutic administration of adrenaline for a child that is bradycardic. Now, somebody who has normal heart rate, now having a physiologic stimulation, releasing catecholamines, of course, it jumps up. So that's sinus tachycardia. Now, in heart failure, of course, there's autonomic dysregulation, sympathetic overdrive, and then the child will have sinus tachycardia. Now, we saw in bradycardia that hypothyroidism can cause bradycardia. Here, thyrotoxicosis can cause it. Hyperthermia, like fever can cause sinus tachycardia. Shock can cause it. Yeah. So, whereas in sinus bradycardia, the cardiac output drops, the sinus tachycardia cardiac output increases, right? But usually well tolerated, provided the myocardium is healthy, right? But there's a problem if it's not healthy. So we like to treat the underlying cause. So again, there is no magic bullet. The sinus tachycardia accompanying thyrotoxicosis will be treated when the antithyroid medications are administered. Yeah. So the sinus tachycardia following shock will be addressed when the volume is corrected. Yeah. Okay. Thank you. So we proceed. Yeah. So we have this interesting tracing, which is one of those tracings that we should identify at first sight. Yeah.
All right. So looking at this ECG tracing, this is an ECG tracing that reflects supraventricular tachycardia.
Yeah.
It's the commonest non-arrest rhythm you will find.
Yeah.
And it's usually
ultimately lead to cardiovascular instability. Yeah.
Now,
so of course, we said commonest non-arrest rhythm. Of course, I'm sure we are aware of the arrest rhythms. Shockable, non-shockable. The shockable being ventricular tachycardia 1, which we will discuss. Yeah, and then the ventricular fibrillation. The non-shockable being pulseless electrical activity and asystole. Yeah. So, but for this supraventricular tachycardia, it's non-arrest rhythm, right?
So, looking at the strip, would we be able to say this is a sinus rhythm? No, because we can't even appreciate where the P waves are. We can see the QRS complexes, and they are very thin. Like they're not even up to a box.
Yeah, so QRS complex is just the width of a single box, and on the ECG strip, a single box is 0.04 seconds, right? So, and we said if the QRS complex is less than 0.09, then that is a narrow complex QRS complex, right? So the rhythm is non-sinus, the QRS complex is narrow, and this rate is 300, regardless of age, because if we have an infant more than 220 beats per minute and a child more than 180 beats per minute, then that's supraventricular tachycardia with this kind of ECG tracing, right? So this one is 300. We cannot discern the P waves And we have this classic pattern. So some ECG tracings, you just go with pattern recognition, right? So this is supraventricular tachycardia. The firing is the waves, sorry, the automaticity is generated away apart from the sinoatrial node. We'll look at the mechanisms in future, sorry, the next slide to see how come about this. All right, fine. So mechanisms for supraventricular tachycardia. Well, in the previous slide, let's just look at it. Not all supraventricular tachycardia have narrow QRS complexes. It may be wide if there is aberrancy in the QRS supraventricular tachycardia with aberrancy. Yeah, you compare with ventricular tachycardia, they have wide QRS complexes. So what are the abnormalities? It could be supraventricular tachycardia due to re-entry. So if there's a re-entrant tachycardia, it's one of the reasons why a child can have supraventricular tachycardia. In this case, the RR intervals are regular. So if we go back to the tracing we had, RR interval is regular here, right? So we know that this is one of those re-entrant supraventricular tachycardia variants. But of this, we still have AV node, atrioventricular reentrant tachycardia, and then the nodal reentrant AV tachycardia. In the nodal reentrant, in the AV node, we have the tract, the normal tract where there should be an AV nodal delay, then there's an aberrant tract within the AV node. So going retrograde, anterograde, and firing continuously. That's a nodal reentrant. But if there's an accessory pathway across the atrioventricle, yeah, so there's a reentrant tachycardia separate from what the SA node is firing. So we find in Wolff-Parkinson-White pre-excitation, the type where you have the AV reentrant tachycardia, right? So this one has regular RR interval. Yeah, so they want you to automaticity of a single atrial focus, of course, different from the sinoatrial node where the P wave is generated from. There is non-regular RR interval, and we could have a superimposed second degree AV block. So it's important we know that. This could be due to an ectopic focus firing continuously within the atrium, different from the sinoatrial node, or it could be a junctional ectopic tachycardia at the AV node. At the AV node, that junction, we could have something else firing unusually. So in automaticity of a single atrial focus, the treatment modalities given for the reentrant may not work, right? But those is good we know the basic treatment. So if it works, we know. If it doesn't work, we know what we are thinking. Yeah. So apart from the fact that you can know that from the RR interval, but both of them will have tachycardia, supraventricular, excessive heart rate, greater than 220 for infants, and greater than 180 for older children. Right. So the differential diagnosis.
Well, it could be idiopathic in infants. So if you have an infant that you had an ECG tracing with tachycardia and suggest supraventricular tachycardia, in the event that no congenital heart defect was treated with that child, and at that moment, then you start. So the cause is unknown. So it could be idiopathic in infants. But also there's some congenital heart defect, such as transposition of the great artery, Epstein's anomaly, which looks at the tricuspid valves or the echo. Yeah,
so there's atrialization of the right ventricle. So the right ventricle looks bigger, but because the abnormalities of the tricuspid valve and the laxity impinges more on the right atrium, so giving a larger volume of the right ventricle occupying the space, the major space of the right atrium. Yeah, so Epstein's anomaly.
Also in post-cardiac surgery, so usually children that have complex congenital heart defects and have gone through some kind of cardiac intervention, you could also see this in them.
Yeah, so problems along maybe fibrosis that disrupt the normal tract of the excitable tissue and accessory pathway.
So the dysfunction, so basically the manifestations, right? So for infants, now looking at the age of infants, it's quite difficult, if not impossible, for them to really express how they feel. So you might not be able to pick this in good time and they might already present in failure. However, for older children, they might present with chest pain, lightheadedness, fatigue, and palpitation, shortness of breath. So when an older child comes with these symptoms, these are some of the things you're trying to think about, and also why it's important to have an ECG done to confirm what exactly is going on and how exactly do we
so we make what makes sense out of it. Yeah, so we should be quick to do ECGs, right? We should be quick to do ECGs. The head of public relations will speak at some point. We have a WhatsApp group for participants and they could join, and so we can always give services. So ECG taken anywhere can be snapped and sent to do ECGs. Children in heart failure, do ECG. A child with chest pain, do ECG. A child shortness, just do the ECG. Let's pick something and do something about it.
Or at least be sure there is nothing else
Perfect.
to worry about.
Yes. Okay, fine. All right, so still on supraventricular tachycardia, the management,
in terms of the management, we have the acute management, which is when they present and they come with those manifestations, which could either be pharmacological or non-pharmacological. But also, it's quite important to prevent a reoccurrence of SVT. So we'll also be talking about this in the next slide.
Okay.
So for the non-pharmacological management, so basically what we can do without using any form of medical intervention, for infants, we can put their face in ice for about 10 seconds.
So like an ice pack put on the face for like 10 seconds. So that would induce physiologic bradycardia, which is necessary in the setting of supraventricular tachycardia. So this is a diving reflex. So in the simple explanation of the diving reflex, although some more elaborate talk on it, but with the ice pack on the forehead, that is like a stimulus. Now the afferent pathway is the trigeminal nerve, and then it takes the signals to the brainstem where the integrating center is. Now the efferent pathway is now the vagus nerve. Now we know that vagus nerve gives parasympathetic stimulations. So the parasympathetic stimulation from the vagus nerve causes bradycardia. So that's the simple explanation of how this comes about. All the non-pharmacological methods, which are very straightforward, associated with vagal stimulation.
So unilateral carotid sinus massage, gagging, headstand, but however, the headstand is for very flexible, probably people that do aerobics, because it's not something that is easy to achieve. But if you have an older child that has the capacity, of course, it's one of those things that can be done.
I think adolescents, right? So headstand, that's with the head on the floor and the leg up. If it's stable enough to do that, and then pressure on one eyeball, right? So a little more on ice. So ice on the face, 10 seconds. 10 seconds.
Not for a long time.
So you don't want to
induce hypothermia.
Yes. So you're trying to treat a problem, you don't want to create another problem. Ice pack on the face for 10 seconds, you monitor the heart rate. You can come back and do, right? Another simple one is pressure on one of the eyeballs. So this one can be done, pressure on one of the eyeballs.
But of course, not too much pressure.
And not bilateral at once. Of course, if someone does bilateral carotid massage, the person is exiting Nigeria to somewhere beyond, right? Okay, fine. So what's the pharmacological?
So for the pharmacological management, adenosine. So adenosine is given as a push. So it's push because of the short half-life, and then it has both negative chronotropic, dromotropic, as well as inotropic effects.
So it means that it's going to reduce the rate of heart rate, that's the chronotropic. Then it's going to reduce the rate of acceleration, that's negative dromotropic. and then it's going to reduce contractility. Yes. So we know that one of the outcomes of tachycardia is that cardiac output increases. So you want to reduce the contraction, right? And the problem with the tachycardia, whether it's supraventricular or even sinus tachycardia, is that it's contracting so fast and it's not giving enough time for diastolic refill, right? So the diastolic phase of the cardiac cycle, of course, I'm sure we can remember the two phases, the isovolemic relaxation. Yeah, so the filling phase and then the isovolemic relaxation. So if there is not enough time for the filling phase aspect of the cardiac cycle and somebody is just firing, that's like busy doing nothing, right? So we want to reduce that ginger. So we give intravenous adenosine. Now, adenosine is one of those drugs. I know that in pediatrics, we know we want to give drugs slowly. So you want to give IV ceftriaxone slowly, because if you've ever attempted it fast, the child would have vomited on your face. And so you learn to be gentle, you give it slowly. But adenosine is a drug you give push as fast as possible, and then you flush immediately with normal saline. So you want to get, so it has a short half-life. And being that we've discussed the mechanisms of supraventricular tachycardia, the variant that it's very necessary for is a reentrant variant.
So if you give the adenosine and the child's tachycardia resolves, then you most likely would think it's a reentrant variant.
Yeah, the reentrant. So if it could be supraventricular tachycardia and adenosine may not work. In that case, very likely, provided it was given well, because if you give like a gentle, humble doctor, it won't give effect, even if it's a reentrant variant, right? But if it's the variant that gives, keep firing from an ectopic focus, right, it won't work, right? So intravenous propranolol, the beta blocker, for supraventricular tachycardia are seen in Wolff Parkinson White pre-excitation.
Also IV verapamil, but for children greater than 12 years old.
Yeah.
And digoxin as well.
Yeah, but we'll look at the details of digoxin and verapamil subsequently. Yeah. Okay, fine. So this is an algorithm for the management of supraventricular tachycardia.
Right, so the first thing you want to look at is shock present, again, yes or no. But for SPT, regardless if shock is present or not, vagal maneuver is like the first thing you can actually do while trying to institute other form of management, right? So vagal maneuver is done.
Yeah, so basically we also, just to add, we know that nobody's an island. So wherever there is an emergency, you call for help. So somebody is maybe gentle massage on one of the eyes to stimulate, to initiate vagal maneuvers. That can be done. If someone is getting vascular access, very important. Okay.
All right, so the for the pathway that talks about shock not being present, so it will go using the algorithm. So after the vagal maneuver, the next thing is adenosine. However, in this patient, there's already an established vascular access. So you give at 100 micrograms per kg, and then you observe, and then you can repeat this in 2 minutes. And for each repetition, you increase by 100 micrograms per kg. However, if this is done and it's done 3 times and you're still not achieving the needed result, then you might want to consider either giving amiodarone or actually delivering a shock to the child.
Yes. So adenosine again is a good drug that works for the type of SVT that it should work for, provided it was given push, adequate dose, push, and flushed with normal saline, right? So if the child is in shock, so just to simplify shock, there's cardiovascular system abnormality, there's central nervous system abnormality, and the urogenital. So in central nervous system, the pulse is rapid and tready, cold, clammy extremities. In urogenital, the child is not making urine. And in the central nervous, there's altered consciousness. So we find that then the child is in shock. Vagal maneuver, get vascular access. Can vascular access be gotten very quickly? It should be, because if we cannot get peripheral vascular access, then we should be able to get an intraosseous. Yeah, at the like a 2 centimeters below the tibia tuberosity on the anteromedial surface of the tibia. Very easy, just go in and get. So an intraosseous can be gotten. If yes, then we go the adenosine pathway. But if it's still so difficult, then the reason why every health institution should have defibrillator becomes very necessary. So we give a synchronous defibrillation. Yeah. 1 joules per kg can be repeated, giving you repeat the shock. Yeah. So that by direct cardioversion. If that is done, you can now consider amiodarone. So this algorithm is quite straightforward, and in the slides that will be sent to participants, it will be there for them. Now, having discussed the type of arrhythmia we have discussed, we just want to know if our participants are following us. So kindly look at the screen and tell us, what can you say about the heart rate in this unit, right? So we expect responses in the Q&A we are watching. What can you say about the heart rate? And look at the QRS complex. Can you say, so the heart rate, is this slow or is it fast? Then the QRS complex, is it narrow? QRS complex, does it look narrow? Does it look wide? So we'll be happy to get responses in the chat, in the Q&A section. Then what will be your first, so let's get the responses coming first before we proceed. I hope we are audible. Okay, fine. So we have answers flowing in already. So yeah, so someone has said something and the person is correct, but can we wait for other people to see if we are good facilitators? Let's see if we are good facilitators. So someone has, and the person who wrote got it right. But let's see, can any other person make an attempt? Is the heart rate normal for a neonate? And the QRS complex. Okay, so someone has said something different, but also correct. Yes. So can we get responses coming in? The person gave a correct answer for a question that was not asked. The person gave a correct answer for a question that was not asked. All right. Okay, fine. So we'll make progress. So this is tachycardia, right? Because it's an infant, and the marked, if once is below 220, right, it's supraventricular tachycardia, right? Above 220.
It's most likely
it's supraventricular tachycardia, right? Okay, fine. So we have, so someone's heart rate is fast, QRS is narrow. So I can see tachycardia with narrow QRS complex. Perfect. The QRS complex is almost a straight line. So on an ECG strip, it will actually just be one small box and means it will not be more than 0. Yeah, so it's a narrow QRS complex. Now, the heart rate is fast. This is 220. Now, good. So what will be your first consideration in an attempt to treat this neonate? Now, this is a deliberately crafted question to see if you are following us. I will be happy to know that. Please, it's deliberately crafted. What will be your first consideration in an attempt to treat this child? Yeah. So maybe you switch your mind back to the algorithm, right? I think I'm already giving the expo, if anything like that. If you remember the algorithm we treated, what is your first consideration when you have made up your mind that this heart rate is very fast, the RR intervals are regular? Okay, fine. Oh, so we have answers flowing in already. Perfect. So good. 2 people. Okay, so we have some answers, but 2 people got it correctly. And both of them wrote the same thing. Is the child in shock? So that's the first thing you check, right? So whether the child is in shock or not, you can start the non-pharmacological methods, which one of it could be ice on the face. So the person that wrote ice on the face is correct, but you want to consider first if the child is in shock. Because after vagal stimulation, if the child is in shock, the pathway is different. You will want to treat hypoxia, give anti-shock as fast as possible. Yeah. So someone has already, how would you treat? Of course, there is a pharmacological, there's a non-pharmacological. So that's a very good attempt for this case. So we make progress. So we've done the emergency treatment. So how do we prevent the reoccurrence of supraventricular tachycardia?
Okay, so for the prevention, if it's an infant and the child doesn't have low Parkinsonian pre-excitation, then oral propranolol, which is a beta-adrenergic blocker, is the drug of choice. However, regardless of the age of the child, either an infant or not, with or without both Parkinsonian pre-excitation, other beta blockers like atenolol and nadolol can be used for prevention. So specific for infants without pre-excitation, then you give propranolol. Others, you can give atenolol or nadolol. Also, for children that are less than 12-year-old, and as well as those that have left ventricular systolic dysfunction, verapamil is to be avoided, but it's also given as one of those drugs that can be used to prevent. Then in the case that none of these drugs are working, then you're thinking of other measures, you're thinking of interventional treatment, then we can do radiofrequency catheter ablation or surgical interruption of the accessory pathway. However, the duration of treatment and how the medications are tailored are going to be determined based on an individual cases.
Case by case basis. So, but we don't rush to interventions. We don't rush. That's why you can see oral propranolol for 12 months, right? So we don't rush into interventions if the child is less than 2 years, right? Because there's a possibility of spontaneous resolution. And these are children you do not want to say this child is lost to follow up. Lost to follow up in this case is not good at all.
And also remember that it's one of the commonest cause in infants anyway, to be idiopathic, really mean that it's not associated with anything. So it actually could resolve spontaneously.
It's okay. So dealt with supraventricular tachycardia. So let's see another interesting one, ventricular tachycardia. Right. So in this one, the heart rate is fast. Now, we have greater than or equal to 3 premature ventricular complexes. So let's look at the ECG tracing. We pick any lead randomly. So maybe let me pick AVL. So we find these unusually wide QRS complexes that are Bizet shaped. So wide QRS complexes, Bizet shaped. So you look at this is a peak, R peak. This is another R peak. So the negative deflection between them is a T wave. So you have wide QRS complexes that are Bizet shaped, forming premature ventricular complexes. Now, if you can count up to or more than 3 in a lead, then it's ventricular tachycardia. Now, on this ECG tracing, you have everything, you have premature ventricular complexes.
Everywhere.
So this is ventricular tachycardia, right? So if we attempt to count the heart rate here, just pick one of the peaks. Yeah,
going to be about 180.
About 180 thereabouts in between the peaks. Yes. So and once heart rate is between 120 and 200, right? We have, so you see why ECG tracing is important. If we find a child with heart rate of, let's say, like a 5-year-old with heart rate of 190, right? Just counting the heart rate, you do not know the pulse rate or heart rate from auscultation. you cannot tell if it's a ventricular tachycardia or if it's a supraventricular tachycardia. Because for a 5-year-old, it's already 190 is already more than the lower limit of 180. So you cannot tell if it's a ventricular tachycardia or a supra, except you do an ECG. Now, the beauty of it is that ventricular tachycardia has its own unique ECG tracing. So these are ECG tracings that we keep for pattern, we say pattern recognition. Just like we have pattern recognition for the SVT. Yeah. So this is a description of ventricular tachycardia. Now, if we pick any lead again, if we are able to get an imaginary isoelectric line, you realize that the peaks of the R waves are near equal. So you realize that the amplitude, they are regular, right? In this case, you say this is a monomorphic ventricular tachycardia, right? So we'll see something else that is not monomorphic. So the morphology of ventricular tachycardia can be monomorphic, like the one we saw, or polymorphic, where the shapes, the size, the peaks, the amplitudes are different, right? Polymorphic, different morphologies, different heights. But the tosads, the point is, yeah, so if we have a kind of twisting pattern, this looks like barbed wire that is somewhat wire that is twisting around the point. Yeah, so it's a polymorphic. Tosads is a variant of the polymorphic ventricular tachycardia. So it's important we know these two variants of tachycardia. So whatever the ventricular tachycardia, we have differential diagnosis. So what could it be?
Could be structural, so congenital heart defects such as tetralogy of Fallot.
Yeah.
We could also have other heart defects such as hypertrophic cardiomyopathy, dilated cardiomyopathy,
Mitral valve prolapse, aortic stenosis.
All those conditions. Also, it could also be present in pulmonary hypertension, as well as arrhythmogenic right ventricular dysplasia, long QT syndrome, and other metabolic conditions, not primarily relating to the heart, right? Such as hypoxia, acidosis, hyper and hypokalemia, and hypomagnesemia as well.
So even if we stop here, any pulse abnormality, just do ECG. Any pulse abnormality, just do an ECG, right? So we say ventricular tachycardia, there is a rate dysfunction and there's a rhythm dysfunction. Yeah, so it's not sinus rhythm. Of course, you cannot find a P wave, right? It's not sinus rhythm. The rate dysfunction, the heart rate is so fast at some point that the cardiac output drops. Why not? There is not enough time for the filling phase of the cardiac cycle. So the heart is contracting, ejecting, and what do we get? Just busy doing nothing, right? So then there's a rhythm dysfunction. There's a lot of problem with the rhythm dysfunction in ventricular tachycardia because it could rapidly deteriorate to ventricular fibrillation. So in ventricular fibrillation, the heart that should be contracting is just shaking. So it's no effective cardiac output, right? So whether it's a rhythm dysfunction or a rate dysfunction, ultimately there is a drop in cardiac output, right?
Some of these manifestations, of course, is dizziness, chest pain, syncopal attacks, palpitation, and if not taken seriously and picked on time, could actually lead to sudden death.
Yeah, sudden cardiac death is common and it happens really so fast. So children with arrhythmogenic right ventricular dysplasia, any of the cardiomyopathies, long QT syndrome, it's obvious they can easily be picked. So we said any child with any rate abnormality or rhythm abnormality, do ECG. But for ventricular tachycardia in particular, a Holter monitoring, which is longer, because ECG is just like a snapshot of what is happening at that moment, right? So a Holter monitoring can take for at least 24 hours. So it gives the tracing for the whole day. Yeah, it's important. So echo is necessary because of the structural abnormalities
Abnormalities
that
associated with
associated.
it.
So we may not find a significant structural abnormality like in pulmonary hypertension. It may be a Doppler, a hemodynamic abnormality, right? Hemodynamic abnormality. So then electrophysiology studies, very important. So management could be acute or chronic. We will deal with the acute management as we go along in this presentation. Good. So this is an algorithm for management of ventricular fibrillation.
Okay, so looking at the algorithm, the first thing you want to establish is you want to palpate the pulse, right? That's even how you identify if there's a rate or rhythm problem.
Yeah.
So if the pulse is present, then you have a thought process. But if the thought is not, the pulse is not present,
Yeah.
then you start thinking, is it a
Yeah.
pulseless
Pulseless
ventricular tachycardia or ventricular fibrillation? Both of which are emergencies and need to be treated as such.
Yeah.
However, if pulse is present, then
So there's an algorithm for ventricular fibrillation
which will
and
show.
pulseless ventricular tachycardia, which we will show subsequently. But this algorithm is for ventricular tachycardia with pulse. Now, the characteristics of that pulse, whether it's full volume now tells us, or whether it is rapid and thready, right? So yeah, so if there is shock, then a rapid thready pulse, we're thinking of, you want to quickly get vascular access, you want to give amiodarone. So amiodarone is given over 30 minutes. Unlike adenosine that is given push, right? So we consider synchronous defibrillation, yeah, by giving shock with our defibrillators. Now, so if shock, so we say shock present. Oh, perfect. Sorry, we mixed it up. If shock is present, right, in ventricular tachycardia, we do not have the luxury of vascular access. You want to shock. After the first shock, you double the joules, and then you can now give amiodarone. But if there is no shock, see, amiodarone where you stop is where you start if there was no
shock.
Yeah, because at this point you can easily get an access. Yeah, it's okay, fine. So, but if it's a pulseless ventricular tachycardia or a ventricular fibrillation, you shock. You just shock. Yeah, and then you commence cardiopulmonary resuscitation. Then you can give adrenaline, continue cardiopulmonary resuscitation. You want spontaneous return of circulation before you continue. So that's it if there is no pulse and the child has ventricular tachycardia. So, well, we appreciate our listeners so far. We've made some meaningful progress in our presentation today. We are gradually coming to an end, but we'll look at AV blocks, right? Look at AV blocks. Now, looking at the cardiovascular physiology, we said that the depolarization of the sinoatrial node, so the excitable tissue, causes atrial depolarization, which generates the P wave. We know that atrial repolarization is submerged in the QRS complex, right? Now, the depolarization of ventricles is represented as QRS complex. Now, between the P wave and the QRS complex, the PR interval, there is the sinoatrial delay. There is a delay in the pathway, right? Physiology. But if there is a block, then there is a problem. So in AV blocks, there's a problem between the P wave and the QRS complex. So that's like the simple basis for all the AV blocks that we'll be discussing. So while we make this discussion, you please watch out for the ECG strips ahead that we would want you to be able to identify and let's know if we are passing the necessary knowledge
or not. Yeah. So looking at the AV blocks, so there are three main types. There is the first degree, the second degree, and the third degree AV blocks. Yeah. And which as highlighted earlier, the PR interval is very important in being able to establish if this is physiology or there is a pathology going on. So we look at the PR interval. If the PR interval is longer than normal, right? However, looking through the ECG strips, this duration is constant across, then you'll be thinking of a first degree AV block.
Yeah. So just okay. If we go back to the physiology, we said the synovial node, there's a depolarization there, and then there is a delay at the AV node before it goes to the Purkinje fibers to excite the ventricles, right? There is a normal delay, which is normal and vary for age. Now, if that delay is longer by a given, say, a few more milliseconds, but that delay remains constant. So PR interval is longer and it's constant. It's not increasing, it's just that it's longer than normal. Yeah, that's a first degree heart block, right? So it means we are supposed to know the normal PR interval for age. The next step, we have tables to show that.
You can use as reference for that. So, however, if this PR interval is longer than normal, however, in succeeding leads, you're seeing that it's increasing in length. Then you start thinking of Mobitz type 1, second degree AV block. However, if the PR interval is similar to type 1, which is it's long, yes, but it's constant, but you notice a drop bit, which means you don't see a QRS complex in between the P wave, then you start thinking of a second degree AV block.
Mobitz
type 2, second degree AV block. But
so,
but in the third degree.
No, okay, sorry, just some emphasis. So we said in first degree heart block, it's important to have a reference for normal PR interval. But in Mobitz type 1, Mobitz type 2, I don't necessarily need that value. If we see that the PR interval for for a given lead, the first cycle, that's PQRST, you check that the PR interval was maybe normal, then it getting longer and progressively lengthening. So you see that PR interval lengthening over time. You don't need the normal value to tell you that this is Mobitz type 1. Yeah. So if you look at the ECG strip again, maybe take one lead, and you find that for any reason there is a P wave, and after that P wave, there is no QRS complex. That's a drop bit, right? You just simply say Mobitz type 2. Yeah.
However, in the third degree AV block, the bradycardia is usually very obvious. It's really very obvious. And also you notice the P2P as well as alpha intervals are more or less constant. But you can't really associate a significant relationship between the P and the QRS, which means the P wave is just on its own, and then the QRS is
so even if you find a P wave before a QRS complex, let's say it's coincidence. It's an electrophysiologic coincidence, because the PP intervals are constant, the RR intervals are constant. You may not find a P wave if it's submerged within the QRS complex. So this is what we call idioventricular rhythm. The rhythm is the ventricle is beating on its own, the atrium is contracting on its own. There is no relationship among them. This is where somebody say, oh, that is X. When you say somebody is X. So the P wave becomes the X of the QRS complex, right? Fine, so let's see, these are normal values.
So this is the table that just highlights the normal values to expect for the PR intervals based on age. Like we've overly emphasized in this conversation today that for pediatrics, most things are age dependent. So if you know the age of the child, you know what to expect as normal or not.
Yeah, it's okay. So we keep that very necessary for first degree heart block. Very necessary for first degree. All right. So dear listeners, we are happy to present this 2-year-old that has this ECG tracing. And let's just see if you are following us. What can you make of this ECG? First of all, is it normal? Then if it's not, is it one of the AV blocks? If it's an AV block, which type, what type do you think Can you identify a P wave? Can you look at the PR interval? This 2-year-old, let's go back. This 2-year-old has a PR interval, so that's periphery of 1 year. So the nearest, so between 70 and 150 milliseconds. So that's to say like 0.015, like that. Yeah. So let's go. Let's see if we can make out sense from this. So what do we think this is? And by the way, rule of the thumb, once PR interval is as long as or more than one big box, is too long. Once PR interval is more than or as long as one big box, is too long for pediatrics. Yeah, so what do we think? Let's hear. Or do we step up to something harder? Maybe this is too simple, so we step up to something harder. All right, so let's step up to something harder. We may come back to this. Yeah. Okay, so for this, what possibly could this be? Can we identify P waves? Can we identify QRS complex after every P wave? Can we look at the PR interval?
Is it normal? Is it longer? Is it constant? These are the questions to ask.
Do we have drop beats?
Not.
Okay. So we wait for answers. Okay. Wait for the first person who will get the prize of 50 liters of petrol at the current rate, right? Okay, so let's step up to something harder, presumably. Okay. Yeah. So okay. So let's go back to our first tracing. So what can we make of this tracing? All right, so fine, we have answers coming in already. Yeah, and this person got it. Yeah. So while we have our colleagues brainstorming, let's see. All right, so we will take a few seconds to hear a little. Yeah, so first degree hard block, first degree hard block, first degree hard block. So why is this first degree hard block?
Well, we can see that the PR interval is prolonged.
Yeah, so this PR interval is longer than one big box.
And if you look across blood, it looks constant. It doesn't seem to be lengthening.
Yeah.
So that's actually very correct answer.
Yeah, yeah. So we'll send the virtual 50 kg or 50 liters of petrol to this very intelligent response. Okay, fine. Yeah. All right, so we have this question number 2. What possibly could this be? We are gradually winding down. As we are winding down, you could give us response, or we are free to answer your questions in the Q&A box. So, but we want an answer for this. Okay, so let's discuss. Let's see. Okay, we've had somebody to give an answer. Okay, perfect. The same person. Wow. Okay. This is not coincidence. This person has been answering correctly all along the way. Yeah. So if we see here, we see that it looks like something is missing here. It looks like something is missing here, right? So if something is missing, then there is a drop bit. So let's go back to our types of AV blocks. So drop bit automatically is second degree Mobius type 2. Okay, we have more answers. Let's see. Yeah, so we have more answers and second degree Mobius. So just mere looking at the ECG, so for this ECG, I don't need to think about so many things. I realize that this is a P wave that was not conducted to the ventricle. There is a drop bit here. This is a P wave that was not conducted. That's enough. So it's Mobius type 2. All right. Let's go to the final one. So what could this possibly be? First of all, we say in one of the AV blocks, we highlighted bradycardia. And what can you think about the PP interval? Can you identify one P wave, link it with another P wave? Can you identify a QRS complex, R wave, you link it with another one? Okay. Is there any meaningful relationship between the P wave and the QRS complex? Okay, yeah, so we have a very fast answer here already. So this is third degree AV block. This is classical. So we can see one P wave here. We can see another P wave here. We can see another P wave, another P wave, P wave. So the P waves are constant. The RR interval is obviously constant, right? So see, there is a P wave before this QRS complex, and it looks as if it's normal, right? But see the P wave before this one now. See how long it is. See this one, see how long it is. But the PP intervals are constant and the RR interval. So this is like idioventricular reading. Be on your own, like be on my own. All right, so that's for third degree. So yeah, we want to round up. We will get a presentation from one of our colleagues briefly, but we would like to know if we've been able to achieve our objectives. Are we able to identify pulse abnormalities by the bedside? If you palpate, can you tell if it's normal or abnormal? And abnormal in terms of the rates, abnormal in terms of the regularity of the pulse. Fine. So can we highlight normal variants? We know that sinus arrhythmias occur as normal variants, right? Can we interpret ECG findings associated? Can we reflexly identify the abnormal tracings that are classical, like supraventricular tachycardia, ventricular tachycardia? Yeah, good. And then understand the basic care for pulse abnormalities in children, especially especially the non-pharmacological measures, especially the non-pharmacological measures, very, very important. So, so if you have questions, you put in the Q&A box. We will get a brief presentation from our head of public relations. You may want to get details about the general WhatsApp group we've created. So if ECGs are obtained for children, if you have any problem, we have 24-hour service. It can be snapped and sent to that WhatsApp group. We should be able to tell you in a few minutes if this is normal, if this is abnormal.
Hello everyone, good evening. My name is Pamela Abai, Corporate Relations Head in the hospital. Today I'll be giving a brief presentation on the Limit Children Hospital services, what we are known for. So the Limit Children Hospital is an arm of the Limit Hospital located at number 39 Ademola Adetokunbo Crescent, Wuse 2. Is a designated specialty branch for pediatrics, neonatology, and general medical care for children under the system of the 40-year-old Limit Hospital founded in 1982. Our services includes, our advanced services includes, pediatric cardiology, which includes echo, ECG, therapeutics, pediatric neurology, EEG, and therapeutics, developmental pediatrics, which includes speech therapy, neonatology, pediatric surgery, and pediatric hematology. What we do, we deliver excellent pediatric care with obvious guest delight. We facilitate the happiness of families through great healthcare delivery, and we offer comprehensive child health and pediatric services. Our other CME activities include our monthly webinars, our monthly presentation. We actually have collaborations with other hospitals. We come in, we do hospital presentation, we relate with your MOs, with your consultants for easy referrals and collaborations. We also have this service coming up. Excuse me, my slide. We also have a new service coming up. Limit Children Hospital in collaboration with Cardiocare will be offering pediatric interventional cardiology for ASDs and VSDs. How do you refer to Limit Children Hospital? You can give a proper referral letter with your name and your number and your hospital, or you can either call any of the numbers on the screen. You can also send a WhatsApp message to the number on the screen as well. Or you can either mail us at limitchildrenhospital@gmail.com. Yes, kindly indicate your name, your email, your phone number, so we can reach you after attending to your referred patient. You are supposed to receive what we call detailed feedback referral from the Limit Children Hospital, detailing every aspect of service that the patient was attended to it. You can also relate with the referring, with the practicing physicians or experts that gave care to your patient. We do this so that we can keep you up to date as to what happened when the person was referred and what we were able to achieve. You can also consider Limit Children Hospital for the following reasons. Number one, sorry, my slide's not working. Why consider Limit Children Hospital as your referral center? Number one, all medical specialties in pediatrics, detailed feedback referral, which is part of what I mentioned, opportunity to discuss and collaborate with the team on referred cases, 24/7 emergency and next day appointments, comprehensive neonatal care and management, ultramodern world-class equipment and fully computerized system. Yeah, Dr. Peter talked about the medical hub where you can send your ECG, send your cases, and we can collaborate and share ideas. The link on the screen, you can scan the barcode on the screen to join the WhatsApp group, and I can also leave the link on the chat box so you can click in and have direct access to the chat to the WhatsApp group. There you get notification about our next upcoming webinars, our annual symposiums, collaborations that we have, and every other way you can refer and collaborate with Limit Children's Hospital. Thank you very much for your time.
Okay, so thank you. We are open to your questions. Let's see. Yeah. Let's see if you have questions. We are rounding up. Okay. So we really appreciate the fact that you could hang on with us this far. We are rounding up, so we are sure, we hope we've been able to address our objectives. So what's our take-home message today? Maybe my co-presenter has a degree in English language. So take-home message: promptly palpate pediatric patients' pulses purposefully. Yeah, so make sure you palpate. We don't only put pulse oximeter to tell us the value, and you don't only count heart rate with stethoscope. Palpate the pulses. So electrocardiographically evaluate every eccentricity. Once you feel there's something wrong, do ECG. Review results, reassure rightly, then you remedy or you refer, right? So we don't give blind reassurance to parents. Yeah, so this is the end of our presentation. Thank you. This advert of the activities that were just discussed by our head of public relations. You will get these slides as it will be sent to you in using the email that you used to log in. Thank you. Okay, fine. So the link is already in the chat box, in the Q&A, yeah, in the chat box, so you can easily. So it will be sent via email. It will be sent via email. So we appreciate. Thank you from Limi. Yeah. All right. Once again, thank you from Limi Children's Hospital. This is where we are located. We will have another webinar session next month from Limi Children's Hospital. Yeah, and Cardiocare is having webinar also. We will have presentations.
Yes, we have cardiac intervention outreach coming up 26th of March to 29th of March for indigent patients. Maybe you've seen the flyer where you can refer your patients and they will be attended to at a very discounted rate. Cardiocare in collaboration with Cardiovascular Education Foundation will be providing these services starting from the 26th of March to 29th of March. So if you have a patient that is in need of any of the cardiac interventions services that we do in the Cardiocare branch, for instance, angiography, stent, pacemaker, and the rest of them, please scan the barcode. I'm going to put the flyer on the group. Scan the barcode, or you can call any of our numbers to refer your indigent patients. It's not for patients that can afford it. It's for patients that cannot afford it, please. Thank you very much.
Yeah, so a colleague actually called me from UK to ask that he saw it. I hope it's not scam. So I said it's not scam. So it's not scam. It's real. So we can refer patients for that. Thank you.
Thank you very much.
Yeah.
The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.